So, oxygenation in pharmacology, module 15. This is kind of pieces from scattered throughout the concept, the asthma, the COPD. We're not getting into the drugs really for the ARDS. Hopefully, some of this Pharm was covered in your pediatric with asthma, but I'm not real sure. So, the best way for me to do oxygenation is just to give you general drugs in oxygenation. Oh, why did I? Oh, catecholamines. Okay. There are 5 neurotransmitters released at the end of the nerve fiber that go across the synapses, and catecholamines are released during stress. That's your dopamine and norepinephrine, and your epinephrine, which is adrenaline or your fight or flight. Also, in there is your histamines. So your histamines are the contraction of your smooth muscles. So your histamine contraction of smooth muscles that are in your lungs, uterus, stomach, and the dilation of blood vessels. So the biggest thing here is with your lungs, why you're going to give antihistamines and why you're going to give epinephrine in severe allergic reactions. Okay, that's pretty much all for that. Here we come back. I told you we'd keep coming back to the autonomic nervous system. We're looking a lot on both sides, really. But if you look over here on your sympathetic, you have your alpha and beta, your beta 2, which is your bronchodilation. The opposite is your bronchoconstriction. So if it's anticholinergic, it goes against the acetylcholine. Anticholinergic, it blocks bronchoconstriction. And if it works on the beta cells, if it's a beta 2 agonist, it dilates them. Muscarinic is over here with your bronchoconstriction on your parasympathetic side. That's all there. Okay. Agonist, antagonist, again, where it's blocking and working, and you should have these in your head by now. They can either egg it on, help it work, antagonist, or block it. And then there's agonist, antagonists that block the receptor activation by agonists, so they work numerous ways. Bronchodilators, beta adrenergic agonists. So they're going to block beta adrenergic agonists. They're going to egg it on, so they're going to help the beta receptors. If they're non-specific, it's going to hit beta 1 and beta 2. So they're going to affect the heart and the lungs, so it's going to dilate, relax that smooth muscle in the bronchioles, while it's might also cause it tachycardia and anxiety. And then you have your anticholinergics, which I said are going to work on your muscarinic receptors on your parasympathetic side, so the cholinergic side where your acetylcholine is. So it's going to block anticholinergic and block the bronchial constriction and cause bronchial dilation. Then you have the methylxanthine or xanthine with your theophylline here, which your text mentions. They have tables on that goes from page 1063 to 1065 for asthmatic drugs, and it has a class in there for this here. Beta 2 adrenergic agonists. So you want these are the best ones because they're selective. They specifically work on the beta 2 lungs and don't have as much impact on your beta 1 or your heart muscle, heart stimulation. Oh, I was looking here, I forgot to take these off, but these are in your drug handbook. If you want to look, it's a good resource. I want you to learn what I'm telling you to learn, but it's a great thing to know, especially with asthmatic drugs and respiratory drugs, where it is in your drug handbook, because it has a chart in there near the front. Okay, so your selective beta 2 adrenergic agonists. So they work on those beta 2 to stimulate the smooth muscle relaxation in the bronchioles. Short-acting, they're orally, or inhaled, mostly inhaled, albuterol and lev-albuterols, but albuterol's in that name. There's a bunch of brand names for these, such as Pro Air, multiple things, but they all are albuterol. They work immediately. They can last 3 to 4 hours. Sometimes people are in such a bad state, you're doing it every 2 hours or even less. They're short-acting. Long-acting lasts 12 hours. Salmeterol and formoterol. Some people get confused thinking those have steroids in them. They do not. Salmeterol and formoterol are long-acting. So they kick in this kicks in short-acting immediately, lasts 3 to 4 hours. This kicks in about 45 minutes or 2 hours for a COPD and lasts about 12 hours. Your albuterol, the names I want you to remember for your short-acting albuterol is your ProAir, Proventil, and Ventolin. ProAir, Ventolin, and Proventil. Lev-albuterol is Xopenex, which is not supposed to have as much cardiac effect as the albuterol. Some think it works. Cardiologists think it's great. The pulmonologists don't really care. And although they're selective, both can have some beta-1, albuterol especially. Your salmeterol, which is your long-acting, is Servant discus. It's the one that you inhale in the mouth. Contraindications. I did not put them here. Okay, so your contraindications are only true contraindication is hypersensitivity. If they've taken it before and they cannot take it, they react, they have a difficulty, that is your only true contraindication. There are some cautions for beta-2 adrenergic agonists, which is your hyperthyroidism, glaucoma, diabetes, hypokalemia, seizure disorder, and any type of coronary artery disease, including hypertension. Those are your ones to use some caution. Non-selective, where they get the beta-1 and beta-2, they're non-selective. They're short-acting for anaphylactic reactions, which is your epinephrine, which I mentioned that in the beginning, talking about your receptor sites and your catecholamines, because epinephrine is one of your catecholamines, your fight or flight. It hits both your alpha and your beta. It's given sub-Q or IM. These are some myths and facts. It is given straight in at a 90-degree angle, right through the pants. You push and you hold it, and no matter how you're doing, always, always, always have to be followed in the emergency room immediately after administration. And that was actually in an NCLEX prep questions that I was doing in boot camp just last week. So that is something for you to know. Okay, so anticholinergics are anti-muscarinics. The muscarinic are the receptor sites in the parasympathetic nervous system, or I say anticholinergic is how I always think of cholinergic as your parasympathetic side because of acetylcholine. So anticholinergic, it blocks the cholinergic effects at those receptor sites. So rather than bronchoconstriction, that would happen, it blocks it so they have airway relaxation and dilation. The one in this group is your ipratropium or atrovent. That's the only one in this group. Ipratropium, it's your only anticholinergic. It is done in an aerosol or a multi-dose inhaler. Spiriva, that's a short-acting. Your long-acting is your tiotropium. If you notice, there's tropium in both of them, and those your anticholinergic or asking anticholinergic we can look at. Okay, so tiotropium is your Spiriva. It's long-acting. It comes in a capsule. Again, I should have done a picture here because it's a little container. If you haven't seen it, it pops up the top. You put a capsule in, you close it, it pops the capsule, they suck it in. Side effects, there is stoma, which is a dry mouth, and pharyngitis because it's inhaled. They should rinse their mouth after to try to help that. They may need some lozenges because the mouth can get very dry. Because it is an anticholinergic, so can't eat, can't see, can't pee. So you're looking at headache, intraocular pressure, urinary retention, GI distress. So if these are the possible adverse effects, you're going to use a caution or contraindication with narrow angle glaucoma because of intraocular pressure, benign prosthetic hypertrophy because of the risk for urinary retention. So that's how you can remember those. Okay, again, you can go there if you want. You can ignore that. I'm telling what you need to know. I don't want you overstudying and missing everything you need. Corticosteroids often are also used. Again, this is your Pharm handbook. Good resource, but for studying purposes, stick to what I'm giving you. Corticosteroids have an anti-inflammatory effect. We'll cover these in the last module for Pharm for this semester also. These are given orally, inhaled, and IV. Budesonide, fluticasone, and mometasone. These are your other names. They can be given by themselves. These azone and sonide. Azone and sonide means they have a steroid in them, the zone and the side. They have a steroid. Oral candidiasis, biggest thing, and upper respiratory infection because of the fungal. So if you go back here, what was I looking for? Oh, salmeterol. These are like meter doses Metarols. Do not have a steroid. The ones that do are the sonide, fluticasone, fluorescein, mometasone. These three. Oral candidiasis, upper respiratory infection. And sometimes people will be on both. Often they will. Cough, hoarseness, and headache are common adverse effects. Hoarseness because of this oral candidiasis, the upper respiratory, you're watching for it, and headaches, and teaching them to rinse their mouth. The most effective agents for the long-term treatment and prevention of asthma exacerbations. And the chemical structure in the inhaled is altered to decrease the risk of systemic buildup of it, but again, it can be given orally or IV corticosteroids, but here these three are all inhaled. So ignore the oral and IV and focus on these as inhaled, and these are your precautions and your teaching. Different devices. So you have your little thing here, these albuterol and your Atrovent or ipratropium will come in those for your nebulizer treatments. Here's a nebulizer. Hopefully in the lab you have used this or been taught to use this. They have mask and they have just a place to hold, or call it smoke in the pipe. This is weird looking yeah, that's a respule for like your tiotropium or Spiriva. This pops open, you stick a capsule, you close it, they put their mouth on here, they suck it in. And then this is like your Advair, which is a combination of a corticosteroid and a long-acting beta agonist. And they click, they put this in their mouth, they suck it in, and that because it has a combination, you want them to rinse their mouth. Both of these and your little other inhalers all have counts on them, so it counts down to where they know that's part of your teaching. It doesn't hurt to teach them to just rinse their mouth after every one of these. That way they don't mess up and forget. Because they said dry mouth can be a factor. And they used to just use spacers. Oh, I got spacers on the next slide. Spacers used to be like the picture for kids, inhaler and spacer use, but newer studies are really, really recommending everybody with an inhaler use a spacer because the medicine gets into here. And remove cap, shake inhaler, insert inhaler into spacer, breathe out all the way, press down on the inhaler, slowly breathe in, hold your breath for 10 seconds, slowly breathe out. Even without this, it's the same process, and actually came across it in boot camp on reviews. questions on how to instruct a patient on using an inhaler, step by step in order. So you should know that. Xanthine derivatives, that is your theophylline, aminophylline, not used as much as it used to be, but that's your xanthine derivative. Increased sensitivity to carbon dioxide, stimulating the respiratory drive. Helps them to respond to their own body. Non-reversible airway disease, second or third line of treatment. So asthma is a reversible airway disease. Emphysema, COPD, are non-reversible airway disease. So your asthma is reversible, your COPD is emphysema is not reversible. So xanthine derivatives are only used in emphysema, not the initial treatment, second or third line only because of many adverse effects. And it's not used in asthma. It can be given orally as theophylline or IV as aminophylline. Same drug, xanthine derivatives. Oral is theophylline, IV is aminophylline. Definitely learn that therapeutic level of 5 to 15. Very, very important to monitor for that. You're looking for these tremors, nervousness, insomnia, convulsions, palpitations, tachycardia, arrhythmias, nausea, and vomiting. When they get toxic on this, which is common, these palpitations, arrhythmias, especially nausea and vomiting, get significant. The first thing you want to do is stop it, check a level. Interactions with St. John's wort, there goes your cimetidine or Tagamet. I told you it interacts with so many things, and it's an over-the-counter drug. It's terrible. And interacts with oral contraceptives. So St. John's wort, cimetidine or Tagamet, and oral contraceptives will increase the levels of theophylline or aminophylline in the bloodstream, increasing your risk for toxicity. Cigarette smoking, high protein, low carb foods will decrease the effects of your aminophylline or theophylline. It's sometimes easier used in asthma, but it is really the second or third line treatment geared toward emphysema or non-reversible disease. Here's your asthma stepwise treatment. Again, I do not know if this was covered in pediatrics. If it was, it doesn't hurt to see it again. Understand the stepwise treatment is they should do peak flows. I should have put a picture. I didn't put a picture of peak flows and personal best. So people with asthma, they will take monitoring and they get evaluated and they have their personal best listed. And so they want to be to a certain percentage of their personal best. So if they're at a certain percentage of their personal best, they're doing these things. And the stepwise means they work their way from this to this to this to this, and they work their way backward as they stabilize and they go up and down. And they know when to call for assistance. So here's the person step one when they're only using the rapid acting albuterol when they need it. And then they have a long acting. They may be on a low dose corticosteroids such as prednisone for a burst or something. Here, they may be on a Leukotriene. I don't see it here. Did I not give you Leukotriene? No. Monticoolist. Okay, so in here, your Leukotriene modifiers in step 3 or receptor blockers are called Monticoolist or I just said it, singular. Monticoolist. It blocks the Leukotriene receptor that causes inflammation, and this is the step that they're usually put in and sometimes maintained on that. And then here, possibly theophylline, they avoid it as much as possible, but see it's way down here in step 4 if theophylline is used. And here when they use everything and try to work their way backward again. That's stepwise. Pneumococcal immunization for age 65 and COPD is all COPDers should have a pneumococcal. Children already get the pneumococcal There's two, PSV 13 and PSV 23. The 13 children all get, they used to just give the PSV 23 to adults, and now they're finding that they give both. So, recommend, if they've never had one, they should get this after the 65th birthday. If they are asthma, COPD, or have some kind of lung disease, emphysema, smoker, they will get one before the age of 65 and one after they turn 65. If they've gotten it before, the PSV 23 is given 1 year after it's age 65 or older, and 1 year after they have, at least 1 year after they've received their PSV. Okay, let's see if there's anything more on here. Not sure why, but they did a study in 2018, and they 5 different controlled studies with over 2,000 participants, and the ones that had their pneumococcal vaccines, as they should with both vaccines, 1 in 8 did not have a COPD exacerbation. It did not prevent the deaths or hospitalizations or deaths from it, but it decreased exacerbations. Okay, almost there. Flu immunization and COPD, reduction in exacerbations occurring 3 or more weeks after vaccination. CDC recommends annual seasonal vaccination for the COPD. Fluzone is the high dose, contains 4 times the antigen, only for age 65 and older. 24% more effective than the regular vaccine, but it's only given 65 or older. Low risk of hospitalization, admissions, and that is the end of this recording.